Hit me.
Welcome to the Senior Rehab Podcast,
The podcast for rehab clinicians that want to better serve older adults.
And now, your host, Dustin Jones.
Shorts. Hello, friends. This week's Senior Rehab Short comes from Dennis Treubig, who wrote this post on themanualtherapist.com titled A Rant on Straight Leg Raises. The good old straight leg raise. How and why this became a staple of any lower extremity injury/pain/surgery is still a mystery to me. More importantly, with all the advances in our profession, why are clinicians still using the straight leg raise with their patients? I think the straight leg raise as an exercise should be retired from the physical therapy world. Unfortunately, the straight leg raise seems to have developed such a strong foothold in the rehab world. I've had a handful of students over the years, and when I ask them how they plan on improving a patient's quad activation, the first thing they typically say is straight leg raises and quad sets, and I just hang my head and sigh. The other day, I had an orthopedic surgeon tell one of my patients that I wasn't doing the right things and that in order to get his quad stronger, he should do quad sets and straight leg raises. Again, shook my head and sighed. If you ask someone who had PT for lower body injury, I bet many of them will describe the straight leg raise as an exercise they did, and I cringe. To be clear, I have no problem using a straight leg raise for diagnostic purposes, but definitely have issues with it being used for knee strengthening, in quotations. Diagnostically, for a post-op knee patient, I use it to get a gross idea of quadricep muscle activation, and for a lumbar/lower quarter patient, I look at it as a movement pattern. I specifically said quad muscle activation and not strength, because even if a patient has a good superior patella glide and no quad lag, it doesn't mean they aren't weak, or conversely, that they are strong. Case in point, I had a patient a couple weeks post-op ACL reconstruction who had a normal straight leg raise. And when I tested their quad maximum voluntary isometric contraction, their quad index was 40%, 60% strength deficit. This also happens to be one of the reasons why I can't stand it when surgeons use a straight leg raise as a criteria for doing certain things. So on to why I think the straight leg raise as an exercise should be banished from the PT world. Most clinicians who use straight leg raises will probably say that they are using it to improve quad strength. In parentheses, what strength really means is a debate that could go on for quite some time, so I won't get into that. I just want to say that if you think a straight leg raise is really going to improve someone's strength, then you clearly have never worked out a day in your life. If you have, then you should probably take a bunch of continuing education courses before you treat any more patients. And unfortunately, you're also probably not reading this blog. And if you think straight leg raises are an effective way to strengthen the quad, then why do you rarely load it up with weight? And when you actually do, I bet you don't use more than a 5-pound ankle weight. Or better yet, you should throw a 5-pound ankle weight on, do a few sets of straight leg raises, and tell me where you feel it. I bet it will be in your groin. That's because when used as a quad strengthening exercise, the muscles you're really working are your hip flexors, and I don't think you want to irritate a patient's hip flexors because that's something that is really tough to calm down. To the clinicians who say they use straight leg raises to improve quad activation, I want you to take a minute. Go back to PT school and think about the muscle length tension relationship works. If a patient has a difficult time activating their quad and you want to give them the best chance to activate it, why would you put the quad muscle in the shortest possible position, i.e. full knee extension? So the straight leg raise puts your quad in one of the most mechanically disadvantageous positions to contract, and then actually makes the rectus femoris even shorter as you do the exercise. The next time you have a patient who presents with a quad lag with straight leg raise, try this. Have them do 10 straight leg raises, retest the straight leg raise, and watch how they still have a quad lag. Then have them do 10 knee extensions sitting on the edge of the table, retest the straight leg raise, and I bet it will have more of an effect than repeated straight leg raises. The method that is probably the most effective would be to use neuromuscular electrical stimulation to the quad. And don't even get me started on clinicians who use a straight leg raise times 4 in flexion, extension, abduction, adduction with the same ankle weight strapped on. This screams lazy and old school to me. So why are we, as movement and exercise experts, using an ineffective exercise when there are so many other options out there? Not only can we elevate our profession by improving our skills or knowledge, but also by eliminating the BS physical therapy that unfortunately is far too common. I can't be the only one who thinks this way, at least I hope not. So please add your thoughts. Some bold claims by Dr. Dennis Treubig. You can contact him on Twitter at DENNISTREUBIG. Thanks, Dennis. Hit me. I want to thank you for listening to this podcast. The show notes and much, much more can be found at seniorrehabproject.com. I want to encourage you to go there so you can join me and many others in the movement that's changing the face of geriatric rehab. Just go to seniorrehabproject.com, click join, and you'll be able to get access to our private Facebook group, which can basically serve as your virtual mastermind group. You'll get a short and sweet monthly email from me with useful links for you and your patients. And lastly, you'll get 10% off your first purchase from the Senior Rehab store. So all of this can be found at seniorrehabproject.com. And until next time, my friends, do not forget to stay funky.